Hello, friends. Welcome to Parkinson's EmPower Talks, a journey of empowerment and understanding for living your best life with Parkinson's. Kick back, relax, and get comfortable. We're here to make your Parkinson's journey just a little bit easier. I'm your host, Dacy. I'm a nurse practitioner specialized in movement disorders and the Director of Medical Advising and Education for the Wisconsin Parkinson Association. The Wisconsin Parkinson Association's mission is to provide hope, community, support, and resources for people with Parkinson's and their loved ones. And I am delighted to introduce my guest today, Dr. Ryan Brennan. Hi, Dr. Brennan.
Hi, Dacy. Thanks for having me.
Absolutely. I'm going to give a little bit of background for the people who are tuning in to us as far as your experience goes. Dr. Brennan is been born and raised in Kalamazoo, Michigan, and graduated from Michigan State University as a doctor of osteopathic medicine. While there, he began working in a Parkinson's research laboratory and then went on to complete his residency at the Medical College of Wisconsin, and then went into a 2-year fellowship at the University of Nebraska Medical Center in Omaha. He currently practices at Freighter and the Medical College of Wisconsin, and also serves as a distinguished member of the Medical Advisory Committee for the Wisconsin Parkinson Association. Thank you, Dr. Brennan. I really appreciate you taking the time out of your day. Obviously, you just scurried out of your last patient visit to join us today, so I know that your time is valuable. Thanks.
No, thanks. I'm happy to be here.
So today we're going to be discussing the topic of Parkinson's disease variability and the importance of creating a personalized plan of care. And I don't know about you, but for me, I think that when a person is diagnosed with something, their ears kind of perk up a little bit in the community, and then suddenly, that starts to kind of surface a little bit more, and we tune into like that diagnosis, or we start to see people with it more, and it's probably just because we tune into it a little bit more. In my own clinical practice, it was definitely after people started visiting some of the support groups or some of the exercise groups that they then would come back in and go, well, why does Jack have a tremor and I don't? Or, Nancy has this medication she's using and you started this one for me. So that was kind of the basis for this line of question in our talk today. So Dr. Brennan, why do we see different symptoms in different people with Parkinson's?
Yeah, it's a great question. I don't have, a definitive answer as to why, because there's a lot about the underpinnings of Parkinson's, we still don't know. Mm-hmm. We know there's multiple different things that are risk factors for developing Parkinson's: environmental, genetics. And so with all these different factors and not knowing, what, sets this cascade of events off that causes these changes in the brain in each individual person, I think it's hard for us to understand, are those the factors responsible for the variability that we see, day to day in the clinic? Mm-hmm. But, many different things can cause it. We know there's 7 known genetic causes of Parkinson's disease, and even those, then there's different things that are taking place in the brain that result in these changes. So the best hypothesis out there is there's a wide array of different causes that just lead to similar but oftentimes different presentations of symptoms in each individual.
And so because there are different causes, there can be different presentations, basically, is what you're saying. It can look a little bit different in people.
Yeah.
So what are sorry, go ahead.
I was just going to say, absolutely, there's a huge variability in terms of severity or, mm-hmm. How quickly symptoms, once they notice it, how they can progress, from one person to the next.
Mm-hmm. So what are some of the more common symptoms that we see with Parkinson's? And then what are some that we might not experience or might not see?
So I think everybody, associates Parkinson's disease with a tremor. Most people are used to seeing that resting tremor that's worse on one side or the other, and it really is what people associate with that. But oftentimes, before a tremor or even other issues with movement that are the hallmarks of Parkinson's disease, there can be subtle symptoms that develop. So decreased sense of smell, acting out dreams in your sleep, talking, thrashing around, constipation. These are all what we call prodromal symptoms of Parkinson's. And many times those develop years before the onset of something like a tremor. In terms of the motor symptoms, the four cardinal features of Parkinson's disease, like we mentioned, the tremor, but rigidity or stiffness, trouble walking, shuffling gait, balance impairment, and then just slower movement, or what we call bradykinesia.
Mm-hmm. So, you had mentioned that obviously there are different symptoms, and are there different subtypes of Parkinson's? Like, are there different forms of Parkinson's that we know of?
There are. And I think before I delve into those with Parkinson's disease, it's also important to know, there's many other neurologic conditions that can have a lot of overlapping symptoms that may look like Parkinson's, but they are not. And they may not respond to the medications as well. The prognosis or the progression of those symptoms, is usually different in those conditions compared to Parkinson's disease. So it's important to understand that it's not just Parkinson's disease that can cause these symptoms. So that's why it's important to get a good evaluation to tease that out. In terms of what we classify as idiopathic Parkinson's disease, there's two main categories of Parkinson's or subtypes, and that's the tremor predominant, that is by far the most common. But there's also another one that's called akinetic rigid, so akinetic, less movement, slower movement, loss of movement, and then rigid. So they're slow and stiff, but they're not really shaking. Those are the two main, subtypes of what we see clinically. Like I said, there's also, the different genetic causes in terms of the underlying etiology of Parkinson's disease as well.
And I would imagine that would draw people into the doctor at different points in time too. You mentioned earlier about the fact that, you can have loss of smell and constipation and all those things that we might think, hey, that's just the way I am, or that's just growing older, and it might not draw you in, or even lead your primary care provider or even a neurologist to a conclusion that there's Parkinson's disease, in the picture at all. They might just tease it apart and think of it as an individual issue and not necessarily put it all together as Parkinson's disease early on. So I would imagine that it's once these things all present themselves and are maybe a little bit more obvious, that it finally leads somebody to actually get it checked out. And tremor is definitely one of those that either the spouse or the person with it are going, hey, maybe you should get it checked out.
Yeah, usually it's the physical symptoms, that bring it to the attention of the individual, their family, primary care doctors. I don't get too many people coming to see me at this point in time saying, I've lost my sense of smell. Do I have Parkinson's disease? That could change, with, some of the diagnostic improvements with the CSF analysis and the skin biopsy, moving forward, especially if we find that, starting treatments, which a lot of people think, we're able to identify people that will go on to Parkinson's disease, can we initiate treatments earlier that could help slow the progression? We're not there yet. Most people, a tremor usually will catch the eye and get people in to checked out. Sometimes, though, a lot of people will, ignore that to some extent for a period of time. And then, if they're just stiffer and slow, that can be very gradual in
Mhm.
onset. And so they may not notice it. Their primary care doctor, might not really notice it until, they come back next year for their annual and they see a big change in terms of
Mhm.
their posture, facial expression, those kind of things.
Mhm. And I think those two, that especially we chalk up to arthritis and, just working hard all our lives and things like that. So and back issues and things. So it's really your job to try to tease all that out of, what really truly looks like Parkinson's. Mhm.
Yeah, and a lot of times people will have shoulder pain on that
Mhm.
side where the symptoms are worse, and they'll be referred for workup of that, and arthritis or other orthopedic issues, and then only down the line when either those treatments aren't effective for
Mhm.
helping them, or more symptoms start to pop out where people are like, oh, this is starting to look like Parkinson's.
Right.
So it's not uncommon to see that.
Mhm. Um, what about as far as does every person get every symptom? Because there are a lot of different symptoms, motor and non-motor we hear about, and so they're all there. Is it something that a person when they're diagnosed, they're waiting for the ball to drop to get the next symptom, or is that not
Right.
necessarily the case?
And I get asked that, all the time, especially when there's commercials on different Parkinson's disease medications that can be frightening for patients. They'll come in and ask, am I going to
Mhm.
experience hallucinations and
Right.
Parkinson's disease psychosis? But the answer is no. Now, many of the symptoms we touched on, tremor, stiffness, slowness, those are all very common. To the diagnostic criteria of Parkinson's disease, they have to have slower movement. So there will be slower movement or bradykinesia in all patients with Parkinson's disease. And most of them will all have, some degree of stiffness or what we call rigidity. The severity of that can vary. Some people, it can just be very mild and hard to pick up on clinically. But everyone will have a little bit of that typically.
Mhm.
Tremor, roughly 75% of people with Parkinson's disease will have a tremor. Usually that's, one of the first symptoms. If they are going to have it, they're going to see that. But that leaves that other subgroup, the akinetic rigid type, that they never necessarily
Mhm.
tremor. And then there's a whole spectrum of everyone, in between.
Okay. Yeah.
In terms of the other symptoms, in terms of memory issues, cognitive issues, there can be a lot of common features, word finding difficulty, but not necessarily everyone goes on to develop Parkinson's disease related dementia, or necessarily will experience other issues like we mentioned with the hallucinations. So knowledge is power, and we have the internet now, and so people, once they receive this diagnosis, they want to learn more about it, and I'm all for that. But it can be scary when you start to read about all these things. So I think it's very important for people to keep in mind that, okay, just because these things are more common in Parkinson's disease, it doesn't necessarily mean that each individual will have those symptoms. And I try to tell people, don't dwell on that, live
Mhm.
your life.
Right.
The more you fixate on that stuff, the more, you dwell on it. It drives anxiety, and it's just not a good place for anyone to be,
Sure.
living day to day for overall health.
Yeah, it's not a good headspace to be in. Yeah.
Right.
And so like if a person has tremor and they'll look and say, hey, I don't want to have the balance problems like that guy does, or the person with balance problems says, well, at least I don't have the tremor, so they're doing a lot of comparison a lot of times, and often coming in and just wondering if that's something that's coming up. And for me, I usually just say, well, pay attention to the symptoms you came in with, and we're watching to see if they reemerge or not through treatment. And if there's anything new, then you've got to bring it up and we've got to talk about it and see if it's related or not.
Right. Right.
So what about, why is it important for everybody then to have an individualized treatment plan? And what does that look like?
Yeah. Everybody's different. Our
Mhm.
makeup different. Our other health issues, may differ. Our lifestyles differ. Our goals, our desires of what we want to do with our life, differs. Medications that you may be on for those other health issues, differs from one person to the next. So there's no, cookie cutter recipe to treat Parkinson's disease. Fortunately, nowadays we do have many options available to us to help reduce, many of these symptoms. But then another part of that is everyone responds to different medications differently, in terms of how effective is this medication versus the other for that particular symptom for them.
Sure.
And also sensitivity to side effects. Some people are extremely sensitive to even, small doses of medications, and other people don't experience any of those side effects at all.
Right.
So we really have to take into account all those different factors, when you're meeting someone with Parkinson's disease. And then, I include them in the conversation, again, what are your goals? What are the things that you want to try to improve? Can we improve it or not, with different treatment? And then I go over the different potential side effects of the different medications, common ones that we know of that occur. And we make a decision together about, what's the best option for you. And it's also important to know that's going to change over time too, as things we know progress with Parkinson's disease, and we have to adapt those treatments over time.
Right. And I think too, important to set realistic goals so that they're not thinking, the tremor will go away completely and things like that, because otherwise they're just disappointed no matter what.
Right.
And that we can't improve their golf game. So
we can improve it to some extent, we reduce the tremor, but we can't necessarily make your score go down. So yes, realistic expectations is key, especially things like tremor, or later on if people develop some other complications that are common, like dyskinesias. They're going to ebb and flow. And they're going to ebb and flow depending on how people are feeling. If they get anxious or nervous, upset, excited, Packers go into overtime or something, that usually will ramp up a tremor. And it's not always something that we have to be concerned and throw more medications at, but just knowing, okay, I'm excited right now. Once this is past, and I'm more calm, I know the symptoms will calm back down.
And some of that's even in their health history, whether they've had a history of depression or anxiety, and then that's now also it's in there as part of, the current treatment plan too. Or say a person has problems with swelling in their legs, things like that we're always kind of taking into consideration, just their overall, renal issues, all the rest of their health history is part of that picture too. I would imagine that you're considering that whenever you're selecting medications, or just thinking about what's in your holster to use for medications for their treatment plan.
Absolutely. And medication interactions, you touched on, like if people are on certain antidepressants, that will exclude or limit, some use of the Parkinson's medications.
So how do you go about working on that individualized plan for them? Is that just something that is just normal process in your visits, or what do you want them to bring to you for information to help you formulate decisions in your plan of care?
I think I always advise patients to, bring a list of your top concerns. Now, if the list is 100 items long, we're probably not have time to go over every single one, with that visit, and we may need to set up subsequent visits. So I tell people, I try to, especially the first time I meet someone, I ask them, what are the top 3 issues or symptoms you're having, in terms of prioritizing what's the most bothersome. And then I kind of take that and then build on it.
Very good. Very good.
But having that of questions, I think is key.
Mhm.
Writing things down in between visits so you have that list. Because otherwise, we all get busy and
Right.
life goes on, forget. So, keeping track of, what are the most important things in between those visits, so we can really tackle the main issues for you.
I think it's always nice if people write things down too, just because when you get into the appointments, the conversation can get sidetracked and then you forget what it is that you even wanted to cover. But even more so, just tracking, when things happen, like how one incident doesn't make a trend. So,
Yeah.
making sure you're documenting how often it happens, if there's a particular time of day that it occurs, how severe it is or how debilitating that is, if it correlates to a timing of medication or not, if it's away from
Right.
the timing of medication, just because those are all those little bits that we need to be able to formulate what changes we might need to make in the medications. And same if they're having any issues where they feel like it's a side effect, writing down when that occurs. Because trying to pull that up in the visit, we're not always great historians when we're all of a sudden in the spotlight and have to come up with all of that data. And it just makes it much easier for them to express and for us to understand, I think.
Absolutely. Early on, symptoms are mild. I people, track if you feel this is getting worse. Is it intruding on your life, your activities more and more? And really, what's that bothersome level for you that we need to, address it with different treatment options. Later on, it can be a little more challenging with Parkinson's disease when people are on medications and they have fluctuations. But that's like one of the first things I ask patients. I'm like, okay, what gets better when you take the medication? What gets worse when you take the medication? Do those benefits wear off before your next dose? And if the answer to those questions is, I don't know, then it is, for us in the clinic, it's very challenging to say, okay, well, this is the change I would make. So I don't always ask people to, track day to day, hour by hour. But if we are having some of those issues, I do ask patients to keep a log. There's different paper, diaries that are out there that people can utilize. With smartphones now, there's different apps on the phone that can be used. And there's a big development going on in wearable technologies in terms of being able to track Parkinson's symptoms. I think it could make our job and patients' job in terms of tracking these symptoms better. I think the trouble we're seeing is, affordability. Most insurance companies aren't really covering those things. And then just making sure your doctor has access to that information at the time of the visit or beforehand to review that. So I'm hopeful, over time we'll be able to integrate those technologies more. But there's definitely some barriers that need to be overcome right now.
And you made a good point too, that tracking, it doesn't have to be for everybody, and we don't want people to over track either, because you don't want to spend your whole life just focusing on the ebb and flow of your Parkinson's. You should be out there living, and so it might not be for everybody to have to track. But if you're having difficulty and kind of remembering, how often it's happening, sometimes putting it down on a calendar or putting it down into a log or a notebook can be helpful. But we certainly don't want you, watching it constantly, because then that becomes your career in retirement.
Right. Yeah, it just becomes all encompassing, and you don't want that. As you said, you want a life, and for that reason, I won't tell people to do that every day for the next 6 months. Usually, if I really need to get some detailed information, I'll ask people, okay, do this for a week, track things, and then, send me that information or bring it to your next visit. But I think if people don't hear anything else, one of the big things is live your life and don't let this totally consume you. Talk to your doctors about your issues, and, we'll do the best we can to allow you to live that life, but don't let it consume you.
Right. I agree. If you were to give our listeners one empowering piece of advice, what would that be?
I think after our discussion today, is back to that last point, we probably done a little bit. I mean, really just live your life. If symptoms are bothering you and they're keeping you from living your life, talk to your doctor. There may be options to help improve that. We can't take Parkinson's away, as we mentioned, tremor, even with all the good treatments and even surgical options we have for that. It's still likely going to ebb and flow a little bit depending on how you're feeling, but live your life and stay active. Movement is key with Parkinson's disease, maintaining your strength. It's really the best treatment we have to keep people mobile and walking and working on those physical therapy balance exercises. So that kind of overall gestalt would be my best piece of empowering advice.
That's amazing. I agree completely. And we can't let it just kind of get to us and overpower, and we can't become it, right?
Right.
We have to remain who we are. So thank you, Dr. Brennan. I really appreciate you joining me today. Thank you to our listeners for joining us for Parkinson's EmPower Talks, and stay tuned for another empowering podcast. The Wisconsin Parkinson Association is a grassroots organization funded by people like you. To support more local programming like this, visit wiparkinson.org.